Welcome everyone to another session related to respiratory system. So today we are going to discuss lung nodules and masses. This is predominantly a theoretical topic, but questions might be asked in your lungs and 2B Viva exam. In my FRCR 2B Viva exam, I had a case of solitary permanent nodule, and the Viva went on how to differentiate benign versus malignant nodules, or everything on the basis of chest radiograph. I kept on saying that I will evaluate this patient on CECT chest and then image guided biopsy, but they wanted to ask everything about how to differentiate benign versus malignant nodules. Okay, so that is the reason I thought of sharing this lecture today. So without delaying, I think we should start the session. So first thing is solitary permanent nodule. Yeah, solitary permanent nodule is important because you need to remember and you need to know what are the criteria to define solitary permanent nodule, not just for your FRCR 2B exam, but also in your future radiological career. Okay, so there are four things to solitary permanent nodule. The first thing is solitary, means there is a single, discrete, and well-defined lung opacity. What is the size? The size should be 3 centimeter or less. Okay, it should be surrounded by normal lung tissue, and there is no associated lymphadenopathy, atelectasis, or pneumonia. If the chest radiograph satisfies all these four criteria, then you label that lesion as a solitary pulmonary nodule. Understood? Then what if the size is more than 3 centimeter? That then you call it a lung mass. Okay, and for all practical purposes, lung any mass more than 3 centimeter is usually taken as malignant until proven otherwise. Okay, this is how you are going to differentiate solitary SPN from lung masses. Okay, now we'll move on to how to differentiate benign versus malignant lung nodules. So there are 6-7 criteria to it. We will be discussing these 6-7 criteria in detail. So these are calcification, size, growth, shape, margins, air bronchogram, and solid as well as ground glass component to the nodule. So we need to we are going to discuss each parameter in detail. So first, coming to the calcifications, on the basis of calcification, there are 3 patterns of calcification, and on the basis of 3 patterns of calcifications, we are going to categorize lung nodules into benign or malignant. Okay, so the first and foremost thing is how benign calcifications will look like. So benign calcifications will have a central calcification, solid diffuse kind of calcification, laminated layered kind of calcification throughout the nodule, and usually seen in prior granulomatous infections such as tuberculosis, histoplasmosis, and the risk level of malignancy is very low in these cases. Now coming to the second type of calcification, which is a popcorn-like chondroid calcification. Clustered popcorn-like chondroid calcifications, we all know. Where do we see this type of calcification? We see it in cases of pulmonary hematoma. We have seen many more cases of pulmonary hematoma, and this is a benign popcorn type of calcification. The risk level of malignancy is again low. Coming to the malignant type of calcification. So what are the malignant type of calcification? So if you have a lung nodule which is showing eccentric, punctate, dot-like or amorphous calcification, then you can raise a possibility of malignancy, and the risk level of malignancy is intermediate, sorry, not indeterminate, intermediate to high. Okay, and this type of calcifications you see in primary lung cancers and as well as in metastasis. Now coming to the size, so size is the single most important statistical predictor in order to define benign versus malignant nature of the lung nodule. So if the lung nodules are smaller in size, so predominantly smaller lung nodules are non-cancerous, and if the size of the lung nodule is large, then predominantly the chances of malignancies are higher in cases of larger lung nodule. So this is the chart. You don't need to remember each and everything, but you just need to know that as the size increases, see, as the size increases, the risk of malignancy also increases. So if you have 2 lung nodules, one is less than 5 millimeter, another is between 21 to 30 millimeter, then obviously your larger lung nodule will have a higher risk of malignancy, maybe up to 64 to 82%. And as we have discussed, more than 3 centimeter lung nodule is referred as a lung mass, and it is treated as malignant until proven otherwise. Coming to the growth, So what is growth? Growth is a speed at which a lung nodule grows and is the most definitive indicator whether the lung nodule is benign or malignant. And in order to comment upon growth, you don't have to measure the lung nodule only in two dimensions, like in most of the HRCT chest reports, we see that the lung nodule is only measured in two dimensions. Henceforth, since we are talking about how to differentiate lung nodules, benign versus malignant, so volume doubling time is taken. Okay, so there is a reason behind it, because a small borderline increase in the two dimension size of the lesion will have a significant increase in the volume of the lesion. Okay, for that reason we have to always mention volume of the lesion in chest CT scan and not just 2D dimensions. Okay, there are few exceptions to it. We'll come to exceptions at the end, but before that we need to see how the volume doubling time is indicator of benign nature or malignant nature. So if the volume doubling time is less than 30 days, that means the lesion is growing very fast, and it is usually seen in cases of infections. Now, if the volume doubling time is more than 400 days, that means the volume doubling time means there is a very slow growth, or maybe there is a stable growth, and usually this is a marker of benign lung nodule. Now, there is a in between. If the lung nodule is growing more than 30 days but less than 400 days, that means it is a danger zone, and where you have to raise a possibility of malignancy in such cases. Okay, understood. Now there are few exceptions to it. First exception is semi-solid or ground glass nodule. So ground glass nodule, we all know that few adenocarcinomas will show ground glass nature on HRCT chest. Okay, then how to say whether ground glass nodules are of benign or malignant nature? So since ground glass nature or semi-solid nature of the lung nodule is associated with malignancy, and these semi-solid and ground glass nodule will show volume doubling time more than 1000 days. Okay, still if it is more than 400 days routinely, then we consider that is a benign kind of lung nodule. But if you are if you get a case of HRCT chest where there is a semi-solid lung nodule or ground glass lung nodule, you have to keep following it up for next more than 1000 days, because these lung nodules are frequently associated with adenocarcinomas, and even after the volume doubling time is more than 1000 days, that is the reason the respiratory physicians keep following such lung nodules for a very long period of time, for more than 3 to 4 years. So they are concerned with whether the lesion is cancerous or not. Okay, but on the other hand, certain lung cancers such as squamous cell or small cell lung cancer, the volume doubling time in these lung cancers is very small, less than 30 days. Okay, so even after having less than 30 days volume doubling time, possibility of small cell and squamous cell lung cancers are not completely ruled out. Coming to the next parameter, that is a shape. What is the physical shape of the lung nodule? What are the border characteristics that will define whether the lung nodule will have a higher chances of malignancy or not? Okay, so we will first discuss the shape, then margins, and then surrounding tissue. So coming to the shape first, which shape will define benign features and which shape will define malignant features? We all know that if the lung nodule is irregular, asymmetric, or multilobulated, then these features will favor malignancy. If the lung nodule is perfectly round, smooth, oval, and sharply polygonal, then that will favor benign nature of the lung nodule. Coming to the margins, so if the margin is spiculated, microlobulated, or ill-defined, that will favor malignant nature of the lung nodule. If the margins are sharp, well-defined, smooth, and distinct from the lung tissue, that will favor benign nature of the lung nodule. What about the surrounding soft tissue? Also, because of the malignant nature of the malignant nature of the lung nodule, it will have pull effect on the nearby structures because of the fibrotic kind of nature, because of the spiculated kind of nature of the lung nodule, that will pull on nearby structures, causing architectural distortion. So if the adjacent structures are getting pulled on, then you can raise a possibility of malignant lung nodule if there is a mass effect, if there is a there is some push on the adjacent lung tissue without distorting adjacent lung structures, then you can raise a possibility of benign nature of the lung nodule. Coming to the margins, so lung nodules on the basis of outermost boundary interaction with the adjacent healthy lung parenchyma, that will define how the lung nodules are called, whether how is the percentage of malignancy. So if the margin of the lung nodule is speculated, that means it is sharp lines radiating outward from the lung nodule, then the probability of malignancy is very high. If the margins of the lung nodule are microlobulated, that means distinctly uneven, bumpy and notch borders, then the probability of malignancy is intermediate to high. Okay. If it is margins are lobulated, that means if the margins are smoothly wavy, multi-lobed contour resembling a cluster of bubbles, then the probability of malignancy is intermediate. If it is smooth, that means crisp, perfectly defined, sharp boundaries, then the probability of malignancy is low. Okay. Coming to the air bronchogram. So we all know, if you see air bronchogram, then we frequently label that condition as a benign and inflammatory condition such as pneumonia. But in presence of a solitary well-defined lung nodule, it is an independent risk factor that strongly suggests malignancy. So how the appearance of air bronchogram will, you will have to see on the appearance, and based on the appearance, you have to raise a possibility of benign nature of the lung nodule or malignant nature of the lung nodule. So first we'll see the airway structure. If the airway structure is smooth, uniform, branching pattern is seen, and it is showing normal tapering of the airway, then you can raise a possibility of benign nature of the lung nodule. If it is airway structure is irregular, distorted, twisted, and dilated air tracts, then you can raise a possibility of malignant lung nodule. What about the bronchial border? If the airway runs completely and clean throughout the lung nodule, then you can raise a possibility of benign nature. If there is abrupt truncation or obliteration of the bronchial border, the tube is suddenly pinched off or cut off, then you have to think of malignant nature of the lung nodule. What about the internal appearance? If the internal appearance is showing tubular air columns typical of lung consolidation, then obviously that is a benign. If the internal structure is bubble-like or cystic pseudocavitation spaces, then you have to think of malignant nature of the lung nodule. So these air bronchogram patterns are frequently seen in infectious pneumonia or organizing pneumonia, and this type of airway patterns are frequently seen in primary lung adenocarcinomas or lymphoma. Coming to the last part, what are the components of the lung nodule? How much is the solid component? How much is the ground glass component? So depending upon solid and ground glass component, the risk level of malignancy is given. So if the lung nodule is purely solid, that means there is no ground glass component to it, then the risk level of malignancy is very low, that is up to 7 to 9%. If it is completely ground glass, there is no solid component to the lung nodule, that means 100% hazy cloud-like lung nodule with no solid component at all, then the risk level of malignancy is intermediate between 18 to 34%. Then if the lung nodule has both solid as well as ground glass component, that means the risk level of malignancy is very high. Okay, so whenever now on, if you encounter any lung nodule having both solid as well as ground glass component, then you have to raise a possibility of malignancy, because in those cases the risk of malignancy is almost more than 50%. Okay, so if you biopsy such lesions, there are more than 50% chances that the lung nodule will turn up malignant. Okay, so thank you guys. We have come to the end of the session. I'll see how many respiratory related topics are remaining. I'll try to cover that. If you have any suggestions, do let me know. I will try to cover those topics too. Okay, thank you guys. Bye. Have a good day.